The most prevalent and very hazardous, one of the hazardous diseases in the cardiovascular system is the high blood pressure, that is hypertension. So it's good to start with the high blood pressure in the morning session itself. So the topic given to me is ambulatory blood pressure monitoring. Is it, for all? And what is the difference between the office blood pressure measurement and the ambulatory blood pressure measurement? Does it matter? And if so, how does it matter in terms of a mortality? So we know the blood pressure is by definition, is the lateral pressure exerted when the blood is flowing in the vessel. In the simpler terms, the hypertension is, we all know the higher than the normal blood pressure is one of the most important contributors to morbidity and mortality in general, and more so in the cardiovascular system like strokes and the MI. But we also know it is dependent on many factors like intrinsic and extrinsic factors, and a single value probably may not be the true representation of the actual blood pressure. This is the concept probably for the evaluation of or the emergence of the ambulatory blood pressure monitoring. So we know the blood pressure is variable minute to minute, probably from morning to evening. There are various concepts, various principles, various factors that were discussed, and probably let us see how does this ambulatory blood pressure monitoring really matters. So this disease is, we all know, it has an impact on, is associated with 69% of first myocardial infarctions, and 74% of the cases of coronary heart disease, 77% of the first strokes, and the 91% of cases of heart failure. So this is the strongest association with a cardiovascular disease and the strokes with the hypertension. This is one way good because it is the single most disease associated with all these issues, probably can be tackled better. At the same time, there is a lot of practical issues that are coming in our way to treat or to establish the diagnosis of hypertension. So there are various, the thought processes. We know the 2 millimeters systolic blood pressure reduction results into 7% reduction in risk of ischemic heart disease mortality and 10% reduction in the risk of stroke mortality. So that is the power of, or the value of bringing down the blood pressure. We also know the lower the blood pressure, the better the results or the outcomes. So even though the question is how lower it is, it should be. 57% of all stroke deaths and 24% of all CHD deaths in India. And the question is, how do we measure? Generally, conventionally, we have been measuring decades together at one reading, or sometimes very scientifically 3 readings, and now the emergence is probably the concept of emergence into it is a continuous blood pressure monitoring or the ambulatory blood pressure monitoring being done either half an hourly or 1 hourly as per the different protocols that are mentioned, and probably taking average of or mean of that and then establishing the diagnosis of hypertension. That is the basic concept of ambulatory blood pressure monitoring. So this is how the system looks, we all know. And even though recently there is a cuffless ambulatory blood pressure monitoring also is available, but I am not going to talk all those things now. The patterns that can be determined by means of ambulatory blood pressure. Obviously, there are, if you see, there are many aspects like the pressures, then the rhythm. These are all being covered under the ambulatory blood pressure, which is not a possibility with a clinic office blood pressure. That is where this is scores over. And the interpretation of this, see, this is basically a 24-hour average blood pressure, daytime blood pressure, nighttime blood pressure, and the systolic blood pressure load can be assessed, and the diastolic blood pressure load can be assessed, and the nocturnal dipping of the blood pressure. These are really an entities, each itself is an entity to be discussed. Average readings or the normal readings that are considered as normal 24-hour systolic blood pressure is less than 115 by 75, and the daytime is less than 120, and the nighttime is less than 105 by 65, and the hypertensives are labeled as more than 130, and the more than 135 as the daytime, and more than 120 is the nighttime. These are the guidelines given. So the ambulatory blood pressure values, definitely very important to understand whether somebody is really an hypertensive or probably having a high blood pressure, high normal values, or is it developing a stage 1, stage 2 hypertension. And it is one of the important tools now recommended by the international agencies, authorities also as a class 1 recommendation. The nighttime average systolic and diastolic blood pressure should both be at least 10% lower than the daytime blood pressure. So these are the points to be considered. Why should we take an ambulatory blood pressure at all? The blood pressure load, as I was telling, is also can be calculated by this. And this is the crux of the ambulatory blood pressure monitoring again. So what is true normotensive individual? What is a white coat hypertension? What is sustained hypertension, which probably everybody knows? And what is masked hypertension? This is the 4 quartiles that are described. If you take one side, the clinic blood pressure, and the other side, the ambulatory blood pressure. Probably if the clinic blood pressure is normal and the ambulatory blood pressure is also normal, it considered as a true normotensive individual. When the clinic blood pressure only goes up and the ambulatory blood pressure is remaining the same, probably white coat hypertension is a possibility. And when the opposite happens, like ambulatory blood pressure alone is high and the clinic blood pressure is normal, called as a masked hypertension. And if both are high, that is a sustained hypertension. So we know this is various mechanisms or the concepts or the schools of thoughts are available. The main reason is an anxiety. This is one of the commonest group of people that are attending now in many OPDs. And it is recommended that a patient with a mild to moderate elevation in blood pressure should not be diagnosed with a hypertension unless the BP remains elevated after the probably the 3 visits, unless there is an evidence of ongoing a target organ damage. So those with a white coat hypertension had a significantly higher rate of all-cause mortality during 16 years of follow-up as compared with the persistent normotension. So that is the importance of a white coat hypertension. The another entity is a masked hypertension, is defined as a normal clinic blood pressure and a high ambulatory blood pressure. This condition is the reverse of white coat hypertension, as I was telling. The clinic blood pressure of patients with a masked hypertension may underestimate the risk of cardiovascular disease. That is the reason why we need to establish all these entities individually. So masked hypertension has been associated with an increase in long-term risk of sustained hypertension and cardiovascular morbidity. That is the impact of it. That is an importance to understand what is masked hypertension and how to label it and how to treat it. So this is the load, the blood pressure. The BP load is defined as the percentage of ambulatory systolic and diastolic pressures exceeding 140 by 90 millimeter during the daytime and more than 120 by 80 in the sleep. The overall BP load may also be determinant of a cardiovascular disease. It's the nocturnal blood pressure and the non-dippers. We all know the nighttime blood pressure adjusted for a daytime blood pressure predicted the total cardiovascular and the non-cardiovascular mortality. So there is a trial evidence for that. So there is another thing, something called extreme dipping, that is more than 20% drop in the blood pressure during night time and having an increase in the blood pressure also potentially deleterious. So what are the indications for the ambulatory blood pressure? See, these are the indications what I was telling now. And the potential indications, this is the recommendation in a high-risk group. And there is a concept called ambulatory blood pressure, as I was telling, and the home blood pressure monitoring. There are minor differences, and this is an important area where we need to understand the measuring the ambulatory blood pressure has a class 1 recommendation both by 2017 SCCHA guidelines and 2018 USC guidelines. So we can understand the importance of this. In nutshell, the blood pressure, ambulatory blood pressure monitoring can be regarded as a gold standard for the prediction of risk related to the blood pressure. Since prognostic studies have shown that it predicts clinical outcome better than the conventional blood pressure measurements, in spite of the high cost, ambulatory blood pressure should be offered to more and more patients to more effectively to understand the menace or probably to treat in a better way the hypertension. Thank you.